I'm Kay Morrison. I'm going to be your nurse today. I'm going to be doing an examination on you. Can you tell me what brought you in here today? And then he tells me it's abdominal pain that's been going on for the last month. And so what exactly brings this abdominal pain on? And he said it seems to be something that I eat. Usually it's related to food. And then I asked him, I explained to him exactly what this is all about, that I'm going to be taking his all his information, that I'll be keeping it confidential, and that basically I'll be sharing it with the healthcare team, that I'll be doing examination, and I need his permission to go ahead and do that, and he gave me permission. And so then I'm going to go through the OPQRSTU, and the first being the onset, where it started a month ago, but last night was particularly bad, where he had severe abdominal pain. And then I asked him what he precipitated, what made it come on, and he said it was was the food he was eating. Was there anything that made it better? And he said no, there really wasn't. The quality of the pain was sharp, and basically I asked him where it was, and he said it was the right upper quadrant. And I asked him if it radiated anywhere, and he said it radiated through to his right shoulder. How severe was it on a scale of 0 to 10? And he told me it was an 8. And then timing, did it occur any time, any other time other than just after he ate? And he said no. I asked, does it wake you up in the middle of the night? Was it before meals? Was it with any other kind of food? And the answer was no. And I asked him if there was any other associated symptoms, like did he have nausea, vomiting, did he have any other thing like that happening? And he said no. And then I asked him what did he think it was, and he really wasn't sure. So then I went ahead and asked him other abdominal questions that might have been an issue for him, and such as how is your appetite in general? He said it was good. Any difficulty swallowing? Any food intolerances? Any other abdominal pain? Does he have any nausea and vomiting? What are his bowel habits like? Basically, does he take laxatives? What is his alcohol use? What is his diet for the last 24 hours? Does he have any allergies to food, to medications, or the environment? And then I asked him if he was on any medications, any over-the-counter medications, and basically I explained to him that I would be now that I have the information from him, I would be starting the examination, and I would get his permission from that. So that was where we went from there. And now I'm explaining to him that I'm going to be doing inspection of the abdomen, and I make sure that the abdomen is quite clear. And you just do an abdominal assessment, and you're inspecting. You look at the contour of the abdomen. You look for pulsations, hair distribution. If there's any scars, I'm noting where the aorta is. Whether it's rounded, scaphoid. I'm now going to start auscultating. And so first of all, I'm going to landmark. So halfway between the xiphoid process and the umbilicus, the aorta is midline, and the renal arteries are halfway between that xiphoid and the umbilicus, and then at the mid-clavicular line, you'll find the renals, and that's where we're going to listen. And then the aorta is just slightly to the left of the umbilicus and the center line, and that's where you're going to listen for the bruit, which is a whoosh sound. Then the iliacs are between the umbilicus and the femoral artery halfway on a V shape, and we're going to listen there as well. So that's what we're going to listen to with the bell of your stethoscope. So first, and it's really only a few seconds that you have to listen in those spots. Now to the aorta. You should not hear anything. That's the important thing. You're not really going to hear anything. And again, the iliacs. And then the femorals. And you wouldn't have pants on when you do that. And now we're going to listen to bowel sounds. And you start in the right lower quadrant. And the bowel sound should be anywhere from 3 to 30 times a minute. And if you hear a bowel sound, you move right along. After 50, you shouldn't stay longer than 15 seconds. And then move on to the next quadrant. If you hear good bowel sounds there, you move on to the next quadrant. And it's quite normal to not hear any bowel sounds in one quadrant. That's okay. As long as you hear that 3 to 30 in one quadrant, then that's perfectly all right. But if you hear no bowel sounds in any quadrant, then you must listen for a full minute. And so basically you have to hear some bowel sounds somewhere. And if you don't hear any, then you must listen for 5 minutes total. And I'm telling you, the lights went out, so we have to wait here a bit. So now I'm percussing zigzag across the abdomen. The whole abdomen should be tympanic. You might find dullness over the descending colon or over the bladder if they did not pee prior to you actually doing the assessment. The other thing we're going to be doing is we're going to find the liver. So you go up the right mid-clavicular line and you go straight up towards the liver, and you'll feel dullness right about there, right at the lower rib cage. Then you go up midline and you'll feel dullness, hear dullness about the xiphoid process. And then you're going to mark it. And so I mark where I hear the dullness, and I mark the midline at that point. And then from above, you start at the second intercostal, and you hear the dullness at the midline at about the 5th, and again there. And now we measure the size of the liver, which is between 6 to 12 at the large part and 4 to 8 centimeters at the small tail of the liver. And his liver is within normal range. Now, the scratch test is by putting your stethoscope in that area and seeing if you can actually hear the loudness of the liver. But anyway, we'll talk about that later. So now we're going to find the spleen. The spleen is mid-axilla. I'm getting him to move over so I can hear it better, reach him better. But mid-axilla between the 10th and the 12th rib, and you percuss from the bed up. And at the anterior axilla line, you'll hear tympany. It's dull until you get to tympany. So his spleen is right in that area there. So you percuss from the bed line up. If there was dullness up there, where I'm now, this should be tympany. If there was dullness up there, that would be an enlarged spleen, and that would be abnormal. And that would be called a balance sign. And now I'm going to percuss the kidneys. And this is the costal vertebral angle. There's the costa, which is the ribs and the vertebrae, and you put your hand there and you percuss your hand over top of the rib or the kidney. And if the kidney was swollen, that would hurt him, and he would say so. And again, thump over the kidney, and he would say that hurt. And I'm explaining that to him. And so now what I'm going to do is the light palpation. So light palpation is hands flat, 4 fingers, circular motion over the abdomen, and he's telling me that hurts there. So I move away from it immediately. And you notice the circular motion over the abdomen is between the skin and the muscle layer. You're feeling for any bumps, any lumps, any enlarged organs, or any soreness. And you end up where the soreness was. Now that I'm doing rebound tenderness, hands straight in, deep, and then quick release. And that would cause pain where the hot spot is, which is over by his rib cage. Okay, and now I'm going to do a modified Murphy, which is you put your hand over just at the edge of his ribs, over the gallbladder, and press and get him to take a deep breath. While he's breathing in, you press, and that hurts. So that's a positive Murphy sign. Now I'm doing a psoas sign, so I'm asking him to do a straight leg rise while I'm pushing down, and that tightens the muscle over top of the psoas muscle, and that causes pain over his gallbladder as well. So that's a positive sign as well. So that's the Bloomberg, which is rebound tenderness, and the Murphy sign and the psoas sign that you see there. So at the end of your assessment, which that is the end of it, you've completed everything you need to do, you will give a report. And so basically you will say this 19-year-old gentleman presented himself complaining of abdominal pain. The severity was mostly last night or after a fatty meal, and he does not have a history of abdominal pain. He does have a family history of his mother had a gallbladder problem, but he's never had a problem with that before. On assessment, I found there was nothing abnormal as far as inspection. On auscultation, they were all normal, all within normal range. On percussion, he was tympanic on all 4 quadrants, and all of his liver was in normal range. His with normal size. His spleen and kidneys were fine. And then I did his, on light palpation, I found that he had some tenderness in his right upper quadrant. And then I did rebound tenderness. I found that he had tenderness in his right upper quadrant again. And I did the psoas sign. He had right upper quadrant pain. And I did modified Murphy's test, and he had a positive modified Murphy's. So I would refer him to the physician for follow-up. And then, just as that would be the end of your assessment. So just if we want to go back over this again, the other thing that I would mention was I would remember that we would take his vital signs, but for your scenario, you're not going to be doing that because you don't have time. So remember, you come in, you assess your situation, you introduce yourself and tell them who you are, you identify who they are, you ask them what's wrong, you give them information about what you're going to do and approximately how long it's going to take. You make sure that you tell them that's confidential, you let them know that you're going to be sharing the information, and make sure you get their consent. And then you start asking them basically the questions and make sure that you find out whether they've got any medication, if they take medications, if they have any allergies. You do the OPQRSTU about the presenting symptom. Then you ask all the questions about abdominal things such as the appetite, difficulty swallowing, medications, abdominal pain, alcohol use, nausea and vomiting, bowel habits, abdominal history, food intolerance, what they've been eating. What I didn't ask about caffeine use, but and I didn't ask about his sexual history actually either. Vital signs I didn't do. Then on inspection, just remember these things. And then when you're doing your auscultation, the actual, remember to start in the right lower quadrant, then go right upper, left upper, and left lower. If there's talking about pain in this quadrant, you would probably start and end up there. Basically, stay away from the painful area. One of the things that I wasn't able to demonstrate for you was the scratch test because you can't really hear it. But usually what you do is you put your stethoscope here and you start and basically what it does is really lets you see where the liver is. So when you're percussing, you percuss and you literally, it's tympanic, 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 tympanic until you get here and it's dull. So when you're doing a scratch test, you put your stethoscope here at the diaphragm and you scratch, 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 and you hear a very faint scratch until you get over the edge of the liver, and immediately it becomes a very loud scratch. And it validates. So this is the most valuable reason for doing that is if somebody's got a very protruding abdomen and you really can't, when you're percussing, you think, I can't really tell where the dullness is. If they got ascites or something like that, a scratch test is so definitive. It doesn't matter whether their stomach is protrudent or not. You will still be able to tell where the edge of that liver is because of the scratch test. So I really recommend that you try that at home. Scratch in the middle and scratch up on that mid-clavicular line, and you'll find exactly where the liver is. Remember, the spleen is over here, so it's just keep in mind what that abdomen looks like. Remember to listen to those vesicular sounds, or the different vascular sounds, I should say. Percussion, and it's a zigzag across the abdomen, and then we're going to palpate. So it's a simple little thing. So there you go. 21-minute video.